he had a gallaging fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we call the gallaging fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture, a 17-year-old gentleman, and the forearm gallaging fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this gallaging fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for gallaging fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of gallaging fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the gallaging fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is a 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for gallaging fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures, because the narrow canal and the length should be maintained to, and DR, UJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for gallaging fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking knelling of femur and tense ends higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did tense. So this case was published in International Journal of Orthopedic Sciences. Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic knelling. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is a transverse and short fracture. So the patient lies supine with affected limb elevated and hanging outside the table, so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious, because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic knelling was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb after 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was done 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail back count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases, the radiological as well as clinical picture. As you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the 1 ST surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did. The 15B1 fracture has been treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. 1 bump is due to secondary callus formation, and other at the entry site you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here. ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नैलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को Finally, lower end of the medullary canal तक डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म की मदद से गोल करने के बाद, होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे, और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल, और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को, उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टीरियर जो होल है उसको गोल किया गया है। इस तरह से सी आर्म को एडजस्ट किया जाता है कि वो गोल दिखे, और एंट्रोपोस्टीरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सी आर्म को एडजस्ट किया गया है, और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है, और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the sharp femur. So this time the patient had come to me for the lower third fracture of the sharp femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the every view, it has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we remove this bone out, and then after reduction of the fracture with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ream the medullary canal with the help of 9 millimeter reamer, and it is being reamed with 9 millimeter reamer, hand reamer, and it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. I am doing reaming with a 10 millimeter reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in amplitude, and also in lateral view. This is the oblique view. And after performing in the CR, in both views, we did reaming up to the lower end of the femur, and finally we reamed this fracture with the help of power ream of 11 millimeter. Because the patient is old one, so reaming is easy. It is just to measure the size of the intermedullary canal, the diameter of the intermedullary canal, so what size of the nail should be introduced so that it can fit in the intermedullary canal. The fitting nail can be introduced. So this is the purpose of reaming, because the patient is bone osteoporotic. Throughout the nailing process, reaming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been reamed up to the upper end of the patella, as you can see in the CR picture. You can see in the CR picture. It is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter
11 millimeter nail on cheek, and finally I am hammering the nail inside the intramedullary canal and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented. And finally, I have introduced the appropriate size nail up to the upper cone of the fractal artery. Good position, the fracture is reduced in both view, in the oblique view and lefty view and lateral view. And then I will remove the guide wire before proximal locking, and now I am doing proximal locking after removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. And I am doing proximal locking. The proximal hole in the proximal fragment the near cortex is perforated with the help of 2.5 millimeter K wire, and the distant cortex is drilled with 3.2 millimeter drill bit, and finally we select a proper size 5 millimeter screw for proximal locking, and I am still making a hole in the distal fragment, distal cortex, and now I am tightening the screw, the second screw in the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position, and it is confirmed that it is inside the hole in both FT and lateral view. And now I will do the distal locking by freehand technique. I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with 3.2 millimeter drill bit. As you can see in this picture, and both the screws have been tightened and confirmed in FT and lateral view. The size of the
confirmed in the every view and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted because the effect of anesthesia was nearly off. So it was accepted. And you can see that both in AP and lateral view, the both proximal as well as the distal screw are in place and in proper position. And now I am going to close the wound after forceful wash of the wound so that now I am closing the wound after forceful wash of the wound. Now the wound has been closed. And the surgery is over. So thank you to my assistant, my anesthetist, and all the supporting staff for successful surgery of this 72 years old female for the fracture sharp femur, which had been operated on the other side elsewhere 4 years back. So this is on your whole a successful and well-executed surgery. Thank you. Hello friends, I am Dr. R.C. Thakur, orthopedic surgeon, Chhapra, Bihar. Today I will give a demo of PFN-A2 surgery for an osteoporotic patient for intertrochanteric fracture of the femur. The design of the spiral blade provides a stable fixation of this fracture and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric unstable tie. And this is the post-operative X-ray of the same patient, and now I am going to start my surgery. The skin incision, before the skin incision, I will drop a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeters, as you can see in the picture. So I am feeling the correct point of entry. It should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in epi view it is just medial to the greater trochanter in the piriform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming, I am introducing a bone out at the correct point selected, and then I am confirming this whether this bone out is entering at correct selected point or not in CR picture. So
I am introducing the owl in correct position after confirming the entry point in CR picture, both in MP and lateral view. So this is MP view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position, going medially in AP view, and this is hammered if it is in place inside the intramedullary canal in proper position, confirming in both AP and lateral view, and then I will pull this bone out for 2 centimeters to introduce the guide wire. The depression or groove present in the lateral side will guide this guide wire inside the hole, and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in AP view. And now I will remove the owl. So I have removed the owl, and I'm doing reading of the medullary canal. In the osteoporotic patient, the reading is not required. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the PFN to nail. So, but this is for measuring the intramedullary canal, and I am reaming by number 10 and then number 11 remove, and the size is 11 millimeter diameter PFN as nail selected, and then I am reaming with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reaming this, and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been reamed with 15 millimeter reamer, and now I am introducing the nail of selected size, and I will hammer the reamer with the help of supine. Dry. I am hammering the nail inside the intramedullary canal so that the hole present in the nail comes in the central position of the neck of the femur in AP view, and
spiral blade can be introduced in central position in every view. And now I am giving a incision for introduction of the spiral blade, and this is the buttress nut. My assistant is tightening it, and so that it touches the lateral wall of the femur. And then I will introduce a guide wire sleeve, and a hard and stout guide wire is being hammered in the central position of the neck of the femur. And I'm confirming it whether it has gone in central position in both AP and lateral view. You can see in the picture, it is in very good place. It is central in AP view and central in lateral view also. So I am doing rimming. Some surgeons do rimming up to the lateral cortex only, but I do rimming up to the side of the nail selected. So I have rimmed up to the proper distance, and now I am hammering the spiral blade after confirming it central position in both views. And I am compressing this spiral blade by clockwise movement, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced in proper position, both NELP and lateral view, and then my assistant is attaching the arm for distal locking on the jig. And after measuring the screw size, I am introducing the drill sleeve for drilling the cortex for distal locking. And this is the 2.5 millimeter guide wire. I am introducing, just perforating making a dimple on the lateral cortex. I am hammering this hard and stout guide wire in the lateral cortex. And after confirming it, in CR picture, I am drilling with the power drill, both lateral and the first cortex is drilled, and now second cortex is also drilled. And now I will put a selected size of a screw for distal locking. I am measuring this on the CR. I am measuring the size of and now I am tightening the screw, distal screw. The final tightening is done.
So confirming it, see our picture. The final tightening is being done now. It has been tightened. And now my surgery is over, and this is the happy view. You can see that it is in good position, and this is the lateral view of distal screw. It has been introduced in proper position in the hole, and this is the lateral view. The spiral blade has gone in the central position in lateral view also. So I will give a forceful wash of the wound, and finally I will stitch the skin and close the wound in layers. And I am closing the wound. The wound has been closed. Without any drain. And I will mobilize this patient on second post-operative day. This surgery is well indicated for the osteoporotic patient with an unstable type of intertrochanteric fracture, because the very design of the spiral blade provides a stable fixation, and we can mobilize the patient from second post-operative day. So this is the lateral view, and this is the AP view post-operative. So thank you everybody. My anesthetist, my assistant, my supporting staff. I think this is the well-executed facility for an old osteoporotic patient, for unstable type of intertrochanteric fracture. We can make this patient mobile from second post-operative day, which is usually required. Although this was not a very distressed fracture, but to make the patient mobile, we planned this surgery for this patient. Thank you everyone.
Hello friends, I am Dr. RCT orthopedic surgeon, Chhapra, Bihar. Today I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body. These are usually caused by high energy trauma like fall from height. We are introduced after with fracture healing time was 12 weeks. Average